trialists to present the Prepare 2 trial are Professor Jon Casey from Vanderbilt, as well as Professor Derek Russell from the University of Alabama in the US.
Thank you. Slides, please. We're delighted to be here, and I really wanted to thank this panel and Rob McSweeney and, of course, the other event organizers for a fantastic conference. I know everyone has said that. It's true. This is a wonderful venue and a wonderful conference, and we're really excited to be here and grateful. We are also excited to share with you the results of the Prepare 2 trial, which, as Chris mentioned, will be coming out today in JAMA. This is the Preventing Cardiovascular Collapse with Administration of Fluid Resuscitation During Induction and Intubation trial. My name is Derek Russell. I'm Assistant Professor of Medicine at University of Alabama at Birmingham in the United States. And my colleague, Dr. Jon Casey, will be presenting some of these slides along with me. We're here representing a research consortium called the Pragmatic Critical Care Research Group, which is a network of institutions across the United States interested in studying commonly asked questions that are difficult to study in a traditional manner, but performing comparative effectiveness research, and for the most part so far have been looking at tracheal intubation practices. I have no potential conflicts of interest to disclose. As this audience is well aware, tracheal intubation is a very common procedure required by critically ill adults across the world. It's required in millions of Americans every year alone, and the data I'm showing you here is likely an underestimate of actually how common this is, since this is pre-COVID information that's been published. And despite the frequency of this intervention, how often we do it, and also the brevity of it, it's a procedure that typically takes 2 or so minutes. Severe complications are very common. This is in contrast to in the operating theater, where patients are generally a more selected and controlled environment, and the incidence of complications has been reported in the 1% to 2% range, whereas even if we only consider the hemodynamic sequelae, the severe hemodynamic sequelae of tracheal intubation in the critical care setting, the incidence has been reported up to 40%. Of peri-intubation hypotension, cardiac arrest, or death. And this brings us to an important critical care outcome that's commonly used called cardiovascular collapse. And although there's no consensus definition for this outcome, it is generally comprised of elements that are thought to be important to clinicians and probably to patient outcomes that fall upon a continuum of hemodynamic decompensation during tracheal intubation. And a commonly used definition of this outcome is shown here, comprising the occurrence of either systolic blood pressure measurement below 65 millimeters of mercury, or a new or increased vasopressor requirement assessed within 2 minutes from the end of the tracheal intubation procedure, or the occurrence of more severe manifestations of cardiovascular collapse, of cardiac arrest or death, assessed within 1 hour of the tracheal intubation procedure. Importantly, this composite outcome has been validated and shown to be independently associated with in-hospital mortality, as have each of the elements of this composite endpoint. The physiology underlying this decompensation that's so common in tracheal intubation of critically ill adults is thought to occur by a variety of mechanisms, among which is a diminished venous return or cardiac preload that occurs downstream of application of positive pressure ventilation to the thorax as part of the procedure or immediately afterward, but also sedative-induced effects on vascular tone in the venous and arterial compartments, and a decrease in endogenous catecholamine release that can occur during the unconscious state that's induced with tracheal intubation. Importantly, all of these, either directly or indirectly, are thought to be potentially mitigated by augmenting cardiac preload through providing a pre-intubation fluid bolus. And so this is a unique situation in critical care medicine in which we can foresee that many of our patients are going to decompensate soon and have the opportunity, we hope, to actually avert that using this intervention. For this reason, a pre-intubation 500 milliliter crystalloid intravenous infusion is a commonly used and commonly recommended practice that is thought to be helpful for mitigating the risk of cardiovascular collapse with tracheal intubation. Observational studies suggest that about half of patients actually receive this in practice for this purpose as a means to ostensibly avert cardiovascular collapse. This is also supported by national and international guidelines recommending the routine use of a fluid bolus of 500 milliliters for the prevention of cardiovascular collapse or other hemodynamic sequelae of tracheal intubation, including these two shown here, which are national guidelines dedicated specifically to the critically ill population undergoing tracheal intubation, which I've shown you before may be particularly susceptible to this complication. However, prior data to support this practice is remarkably sparse, and to our knowledge, supported by only one randomized clinical trial that we actually performed in 2019 and reported. This was the Prepare 1 trial, and to differentiate it from the Prepare 2 results we'll be discussing shortly, I'll call it that way today. This is a randomized trial conducted across 9 sites in the United States, enrolling critically ill patients who are undergoing tracheal intubation. And it was testing the effectiveness of a 500 milliliter crystalloid infusion initiated prior to the first sedative drug given, that is induction, for prevention of cardiovascular collapse. This study, as you can see, was stopped for futility at the interim analysis after enrolling 337 patients and found no benefit from fluid bolus for prevention of cardiovascular collapse overall. However, when we looked at potential effect modifiers, we were interested in a persistent or a consistent signal that suggested to us a physiological group of patients who might be more likely to benefit from fluid bolus, namely patients given positive pressure ventilation modalities during the tracheal intubation procedure, as shown here on this forest plot from the Prepare 1 trial, which forms the basis of the rationale of the Prepare 2 trial we'll get to shortly. We observed an apparent benefit from fluid bolus provision in patients who were given non-invasive ventilation or bag mask ventilation during the tracheal intubation procedure. And this has a physiologic plausibility. As we mentioned earlier, application of positive pressure ventilation is thought to reduce cardiac preload, and it seems plausible that a fluid bolus might be more likely to benefit patients who have that occurring. Furthermore, since 2019, when we conducted the Prepare 1 trial, we think that the provision of positive pressure ventilation is much more important, or even more important than it was at the time we conducted that study, in part because of the Prevent trial, which we published at about the same time in 2019, which showed that bag mask ventilation was effective at reducing the incidence of hypoxemia during tracheal intubation and appeared to be safe, suggesting to us that we ought to be treating patients with this modality that seemed to predict a potential benefit from fluid bolus. And so we thought that this justified a prospective randomized trial to actually, hopefully, conclusively assess whether or not the provision of a fluid bolus would be effective in our patients. So to summarize where we are at this point, we've conducted a trial of 337 patients and found that fluid bolus, even though it has a good biologic plausibility and seems like it might be helpful, doesn't appear overall to be beneficial. However, we did also identify that patients treated the way we're now today treating patients when we perform tracheal intubation in the ICU, that is, giving them bag mask ventilation or non-invasive ventilation during the procedure, that group of patients seem to have derived benefit potentially. And so our research question was whether a peri-intubation fluid bolus would prevent cardiovascular collapse in critically ill adults who are treated that way during tracheal intubation. And with that, I will hand over the slides to Dr. Casey to walk you through the methods of the Prepare 2 trial.
Thanks, Derek, and thanks again to Rob for inviting us here. It's really been an amazing week already, really exceeding its reputation as the premier critical care conference. My name is Jon Casey. I'm a pulmonary and critical care doctor at Vanderbilt University Medical Center, and I'm honored to be here today presenting the methods and some of the discussion of the Prepare 2 trial on behalf of the Pragmatic Critical Care Research Group. The PREPARE 2 trial was a multi-center parallel group randomized trial comparing fluid bolus versus no fluid bolus among critically ill adults receiving positive pressure ventilation during intubation. The trial was conducted among 11 sites across the United States. The inclusion criteria were adults undergoing tracheal intubation with sedation for whom positive pressure ventilation between induction and laryngoscopy was planned. Exclusion criteria were limited to pregnancy or prisoner status, intubations too emergent to perform the randomization procedures, or intubations where clinicians felt that a fluid bolus was required or contraindicated. These very broad eligibility criteria were intended to enroll a generalizable population. The trial was conducted with a waiver of informed consent. During the trial, allocation was concealed until randomization. Patients were randomized 1-to-1 to fluid bolus or no fluid bolus in randomly permuted blocks of 2, 4, and 6 stratified by site. Given the nature of the intervention, blinding was not possible following randomization. For patients randomized to the fluid bolus group, their clinicians were instructed to start at 500 cc fluid bolus prior to induction and to infuse as much of that fluid volume as possible prior to the start of the procedure. For patients randomized to the no fluid bolus group, clinicians were instructed not to start prophylactic fluids prior to induction. Data was collected during the procedure in 3 ways. During the intubation procedure itself, a trained independent observer collected high priority data points including oxygen saturation and blood pressure, the receipt of a fluid bolus, the trial intervention, and the volume of fluid received, as well as vasopressor administration, part of the trial outcome. Immediately after intubation, the intubators reported outcomes that they were best positioned to assess, including sedative drug and dose, devices used for provision of oxygenation and ventilation, and outcomes such as aspiration and cardiac arrest. Additional demographics and long-term clinical outcomes were assessed by research personnel from review of the medical record. The outcome of the PREPARE 2 trial was the same as the outcome of the PREPARE 1 trial, cardiovascular collapse. So again, to review that outcome, it's a composite of these 4 variables: systolic blood pressure less than 65 or new or increased vasopressors between induction and 2 minutes after intubation, or cardiac arrest or death between induction and 1 hour after intubation. As we know, and as we've talked about for other trials this week, one of the main challenges in critical care trials is that many trials end up being underpowered when the event rate doesn't match what the pre-planned event rate. To avoid that challenge in PREPARE 2, we pre-planned an adaptive sample size calculation. The initial sample size calculation, which was based on the PREPARE 1 trial, planned to enroll 750 patients. It was calculated that this would provide 80% power at an alpha of 0.05 to detect an absolute difference of 8.75%, or a relative risk difference of 35%, assuming an incidence of the primary outcome of 25% in the control group and missing data of up to 5%. In a pre-specified analysis at the interim, the DSMB calculated that maintaining 80% power to detect the same 35% relative risk difference using the observed event rate in the control group would require increasing the sample size by 315 patients, resulting in the final sample size of 1,065 patients. The statistical analysis plan was pre-registered and published prior to the completion of enrollment in B&J Open. The primary analysis was an intention to treat comparison of patients randomized to fluid bolus versus no fluid bolus, with the only patients being withdrawn were those who were discovered to be prisoners after intubation. The primary analysis was a risk difference between 2 treatment arms. You laugh, but there are cases in the emergency department and ICU where teams are called in rapidly, patients are not in handcuffs, and there's very little you know until the procedure is over. So those were the cases where the prisoner status was only recognized following intubation. So in those cases, you're not, by regulation, it's not allowed to collect any data. So those patients had to be excluded from the analysis. The primary analysis was an absolute risk difference between the 2 treatment arms, calculated using a chi-squared analysis. The secondary analysis included adjusted analysis of the primary outcomes and sensitivity analysis using alternative definitions of the trial population and alternative statistical methods for analyzing the primary outcome. The trial started enrollment on February 1st, 2019, was paused from March of 2020 to August of 2020, completed enrollment on May 24th, 2021, and final follow-up was completed on June 21st, 2021. So at this point, I'll turn it back over to Derek, who's going to take you through the results of the trial.
Thank you, John. So we screened almost 1,600 critically ill adults undergoing tracheal intubation in a participating unit and enrolled excluded approximately 500 of those. The most common reason for exclusion was that the procedure was too emergent for trial procedures to be safely performed. We'd also important to notice that only 27 patients of the screened population were excluded on the basis of the operator feeling that a fluid bolus was absolutely required for prevention of cardiovascular collapse. This left us with 1,067 randomized patients, and after omitting the 2 exclusions for prisoner status being discovered after enrollment that John mentioned earlier, we were left with 538 patients in the fluid bolus arm and 527 in the no fluid bolus arm in our primary analysis. Patient characteristics across the 2 groups were well matched. In general, the indication for tracheal intubation was acute respiratory failure in the majority across both groups. Apache 2-score median was 19. The patient also had a significant amount of hemodynamic instability at baseline, including a 20% rate in each group of vasopressor requirement and presence of sepsis or septic shock in the majority of patients. Etomidate, importantly, was used as the induction agent or the primary anesthetic induction agent in the majority of these patients as well, 75 to 80% in each arm. This is noteworthy, I think, especially at this international conference where induction agents vary widely across countries. And it could conceivably be important for cardiovascular collapse, of course. Compliance with study intervention was, we think, excellent. We were very pleased to see that patients randomized to fluid bolus received a 500 milliliter crystalloid fluid bolus initiated prior to induction 99% of the time, whereas patients randomized to the no fluid bolus arm did not receive a new fluid bolus between enrollment and induction 99% of the time. However, in part to address a limitation of the Prepare 1 trial and also to assess not only the frequency of compliance with the intervention, but also the quality of compliance with this intervention, we did also have an independent observer recording the volume of fluids administered at various time points during the procedure, and saw that we're gratified to see that the majority of patients had received the entirety of the assigned intervention, that is 500 milliliters, by the time the assessment window had ended. So at this point, we've been studying this question for 5 years. This is the second trial. We've enrolled almost 1,100 patients into Prepare 2. And this is an important question, we think, testing something that about half of operators, the data would say, are using routinely, and we need to know if it works or not. So here's what we found. In patients who were not assigned to no fluid bolus, cardiovascular collapse occurred 18.2% of the time. I was trying to build the suspense, but I didn't do that on purpose. So let's see if it'll forward. There we go. I'm afraid that in the patients assigned to fluid bolus, cardiovascular collapse occurred 21% of the time. This gives us an absolute risk difference of 2.8%, which it bears noting that that is in the unfavorable direction for fluid bolus. This is a non-statistically significant difference between groups. When you look at the elements of this composite outcome of cardiovascular collapse, namely new or increased vasopressors, systolic blood pressure occurrence reading below 65 millimeters of mercury, cardiac arrest or death, again, you see no evidence that there's a significant benefit from provision of a fluid bolus for any of the elements of this composite outcome either. We also tested a litany of potential effect modifiers, including some shown here, such as the presence or absence of sepsis and a requirement or a lack thereof for vasopressors at baseline, and could not identify a subgroup that appeared to be benefited by fluid bolus provision for this indication. Shown here, and I apologize for some of the smaller letters, but the y-axis shows you the probability of cardiovascular collapse across the variable shown on the x-axis, which in this case is systolic blood pressure at baseline or at induction. And as you might expect, patients with a lower systolic blood pressure at baseline were more likely to experience cardiovascular collapse. However, we could not identify a range at which fluid bolus appeared to be beneficial. I must be pointing the wrong way, sorry about that. Similarly, we calculated using a previously validated risk score for a patient's individual risk of experiencing the outcome. And although that risk did indeed seem to predict a patient's probability of experiencing cardiovascular collapse, again, we could not identify a range of risk at which patients would benefit from fluid bolus. Neither the low nor the high risk patients appeared to be benefited. We also looked, of course, at a number of clinical outcomes, including our sole secondary outcome of in-hospital mortality, which occurred at about 40% of patients overall for both arms. And I should mention that data for this study was censored at day 28, so this is 28-day in-hospital mortality. And again, no difference between groups that we could prove. Similarly, ventilator-free and ICU-free days, as well as the lowest systolic blood pressure recorded for that patient during the procedure, and the change in systolic blood pressure from baseline to the nadir were all similar across the fluid bolus and no fluid bolus groups. So with that, I'll hand it over to Jon for the most difficult part, which is interpreting this information.
Thanks, Derek. So what do we find? So in summary, we found after the enrollment of 1,065 patients and their randomization to fluid bolus or no fluid bolus with 99% protocol compliance, that administration of a fluid bolus during emergency tracheal intubation did not prevent cardiovascular collapse, with the primary outcome occurring in 21% of patients in the fluid bolus group compared to 18.2% in the no fluid bolus group. Further, there was no difference in in-hospital mortality, the sole pre-specified secondary outcome, or any of the exploratory analyses. Strengths of the trial include conduct at multiple centers, a severely ill patient population with an overall mortality of approximately 40%, collection of trial endpoints by an independent observer, a high rate of protocol compliance, no missing data for the primary outcome. Limitations include that cardiovascular collapse is a surrogate that, while associated with mortality, may not be meaningful in and of itself to patients. And further, that the question we were asking in this trial was limited to the use of fluid bolus in preventing cardiovascular collapse during intubation, and it may not inform other uses of fluids, such as rescue fluids. So here are the two trials that have been conducted in this space. So the PREPARE trial on the left, which was published in Lancet Respiratory Medicine, which asked the question, does a fluid bolus help among this broad population of ICU patients? It found no signal overall, but had this very provocative secondary analysis in which patients who were receiving positive pressure appeared to benefit. That's a very strong physiologic rationale, in that those patients are receiving additional positive pressure, have decreased cardiac preload, and they're a group who might particularly benefit from a fluid administration. And that signal was robust in multiple subgroups: bag mask ventilation, non-invasive ventilation. That seemed to be an important enough signal to prompt us to spend 3 more years conducting the PREPARE 2 trial, published today in JAMA on the right. And yet you can see the results are strikingly similar. So in both trials, there was no difference in any component of cardiovascular collapse between the fluid bolus and no fluid bolus group. And even the overall rate of the outcomes between the two trials is really strikingly similar. So why is that? We had this very strong physiologic rationale. We had a prior trial that showed a group that appeared to benefit, and that we went on to test that hypothesis in a subsequent randomized trial. And I think you should ask the same questions you ask whenever you see a trial that appear to not show a benefit, and say, are these results meaningful and accurate? So the first question is, did we enroll the right patient population? So did we enroll patients likely to benefit from fluid administration? As we've talked about, we chose this population carefully based on a strong physiologic rationale and evidence from a prior randomized trial. Further, there was no evidence of fluid benefit overall or in any subgroup. So it doesn't appear as if targeting a different population within the trial would have led to different results. I think the next question should be, did you exclude patients who were likely to benefit? This is a pragmatic trial. The intervention's embedded among clinicians. Did they identify and exclude patients who would have benefited? And we were very careful in tracking the reasons for exclusion. And the answer was no. Only 27 patients, only 1.7% of the screened population, was excluded because clinicians felt that they had to have a fluid bolus. Did you enroll a high enough risk population who were likely to experience the outcome? The answer again is yes. The rate of the outcome was 20% for the primary outcome and 40% for mortality. And further, there was no evidence of a benefit from fluid bolus in those at either high or low risk of the outcome. I think so. The next question is, did you give the right intervention? Did you adequately separate the groups? I think the first part of that question is, what was your intervention? Did you choose the right intervention? So the intervention in this trial was a 500 cc fluid bolus. We chose that for a variety of reasons. The first is that that volume of fluid has been shown to be sufficient to affect cardiac output. It's the same volume that had been reported used in prior observational trials that were the foundation for the PREPARE 1 and PREPARE 2 trial. The same volume used in the PREPARE 2 trial in which this group of populations appeared to benefit. And it's the same volume of fluid recommended in multiple international guidelines. Further, in addition to prescribing that volume of fluid, was that volume of fluid actually delivered? So shown here on the right is the volume of fluid administered at the 3 time points in the trial: enrollment, induction, and 2 minutes after intubation. And as Derek noted during his presentation, the fluid bolus group received a median of 500 cc's of fluid compared to 0 in the no fluid bolus group. I'll also just say, as a clinician who, in addition to conducting the trial, enrolled many patients in the trial, this is a hard intervention to deliver. You're called into the room for these very emergent interventions. It's pretty common that everything's set up and that you're the head of the bed trying to deliver more fluid before you start the procedure. So I would say that it's a fair question, was 500 cc's enough? But it was very challenging just to deliver this volume of fluid during this very emergent procedure. Was the sample size too small? As noted, we pre-planned an adaptive sample size to avoid this problem and increase the sample size from 750 patients to 1,065 patients to ensure adequate power. Further, the effect estimate favored the no fluid bolus group, and it's very unlikely that the enrollment of more patients would have revealed a benefit from fluid. As noted, there was no suggestion of benefit in any subgroup and no suggestion of benefit in any secondary analysis or sensitivity analysis. So what's the full body of literature on fluid bolus during emergency tracheal intubation? And I think just stepping back again, this is a really critically important procedure. This is a 2-minute procedure during which 40% of our patients experience bad outcomes. And in many studies, up to about 1 or 2%, 1 in 25 patients die during this 2-minute procedure. And during this procedure, about half of providers currently give a fluid bolus, a 500 cc fluid bolus, trying to prevent cardiovascular collapse. What do we now know about that intervention? There are 3 basic studies: the 1,065 patient PREPARE 2 trial that we just presented, the 337 patient PREPARE trial, and a recently published propensity score analysis of the Intube cohort study. All 3 studies show no benefit, and further, all 3 studies show an effect estimate that favors harm. So I think together this is pretty convincing evidence that we should not be routinely administering fluid bolus to prevent cardiovascular collapse. So I want to thank Chris Seymour for being here to discuss the trial, and to JAMA for being really great partners in working through the review process for this trial. As Chris mentioned, the trial is being published today in JAMA. This is the visual abstract. And this, as everyone knows, trials like this are a huge effort. This is only a partial list of the people who contributed to this trial across our 11 sites, in addition to the hundreds of clinicians that enrolled their patients and help us to deliver this intervention. So thanks to the members of Pragmatic Critical Research Group, and thanks to all of you for having us.
So congratulations. Thanks a lot for presenting that data. We have a lot to discuss, and leading that off will be Tony Gordon, Professor of Intensive Care Medicine, Imperial College London. Thanks, Tony.
Thanks, Chris. Thank you. It's a pleasure, as everybody has said, to be back face-to-face at this fantastic meeting. I have to say, my pleasure was going to be entirely down in the audience rather than standing up on the stage. But when Rob asked you at the last minute to stand in, he's such a fantastic host, how can you ever say no? But therefore, obviously, I have no slides because I've only read this on the plane over, and unlike Simon, I didn't have time. My flight was not as long as his from Australia. I only had time to read the paper once. So I've made some notes. I also realised that how much we use slides as a crutch in order to give a talk, so I have a few notes. I think, first of all, as we said, congratulations on conducting an important trial. As we've been hearing, all trials are difficult to conduct. Emergency medicine trials are really hard to conduct. And conducting any trials in COVID, whether they be COVID trials or non-COVID trials in COVID has been really difficult. So well done for completing the trial and also giving a very clear answer to the question that you asked, and which is clearly an important research question, hearing how many cases of emergency intubation happen per year in the US, 1.6 million. It clearly is an important clinical point for which we need good evidence. I'd also to give a clear answer in the reading. I really appreciate the fact that it's a clearly written paper and supplements, which is important. And we've heard that trials are difficult to do, and they are, but also trials are also simple. To conduct a good trial, you always go back to the simplicity. And I remember sort of when learning about writing protocols and GCP, they said it's really quite simple. Write the protocol that says what you're going to do. Then when you conduct the trial, do what you said you were going to do. And then importantly, when you write it up, say what you did. And what I've noticed, I think, in the time I've been involved in clinical trials is that reporting has improved massively. I think the supplements nowadays that are online enable that. So again, congratulations. As we heard, most people won't even read the whole paper, and would certainly won't read the supplement. But when you do read the supplement, all your definitions are clearly there for all your events, including like how you describe what an intubation event is, like the laryngoscope enters the mouth. It's really well done, and I think that's important. And it certainly helps when you're designing other trials to see, so we're not reinventing the wheel each time. And I congratulate you for following up a subgroup result with an enriched population to provide that stronger evidence. And I think this trial shows, again, warning, we've talked about subgroups, how we shouldn't overinterpret them. And we'll maybe come back, though, to that subgroup effect. I also like the fact that you adapted your trial size and that process was very robust. Obviously, I have become an enthusiast for Bayesian trials, which allow adaptation perhaps more easily. But again, I thought this is a good point that even with a frequentist design, you can still adapt. So it doesn't matter which approach you take. There are important adaptive processes, whatever statistical approach. We'll come back as to whether the trial was maybe underpowered to start with. Again, maybe it's a UK-specific thing, but our funder now always really requires 90% power. And an effect size, 35% relative effect. For a physiological outcome, maybe it is plausible. I think for clinical outcomes, maybe less so. Then coming to areas I just want to question about. The primary endpoint was a composite endpoint. And when I read it, first of all, cardiovascular collapse, I thought, well, that's important. That's what you want to prevent. But then listening to Marion's talk yesterday, when she pointed out with a composite, she said there are a few important characteristics. Are they all equally important? Hypotension or death? I don't think it's controversial to suggest they probably aren't equally significant. Are they all patient-centered? I don't think the patients will have known they had a bit of hypotension. And importantly, they all need to go the same way. Here they do, and so that's fine, and it's very clear there's no signal at all. But what about if they hadn't? What if there had been a 10% improvement in the physiological outcome, but a doubling of the mortality? That would have still come up as a positive trial on the primary outcome, but death rates would have increased. So maybe something to discuss. Is it better to include it? I understand because you want to collect all badness, but would it be better to have a primary endpoint that was physiological based, if that's what felt to be done, and then just report the mortality as purely a secondary outcome? Maybe we can discuss. Obviously, the intervention was unblinded by nature. It would be very hard to blind it. And importantly, I think you had independent data collectors, which again, I think is important. If you're the operator, you may be less inclined to report the badness that happened with your procedure. So I think that was a strength as well. Does it rule out, there still obviously could be biases. Patients, the clinicians knew what they were giving. Could they have sort of gone heavier on the sedation, knowing that they'd given fluids, and therefore you just got that null effect. Again, your supplement is good. It contains all the information. There's no evidence of that. So it looks like all the treatments were balanced. Other questions I'd have, this 2 minutes, I know it's come in other publications. It's not an area I do research in, but is that really important? What about the effects after 2 minutes? I find when I do get hypertension, because it does occur, there's sort of UK anaesthetists would say, well, then reach for the silver inotrope. Just put the laryngoscope in and the blood pressure usually comes up. But then I find often it will collapse again afterwards. What about in that first hour? So I'd be interested to discuss why not look a little bit longer than just 2 minutes. As a comment, I would say, yes, I thought practice does vary. I haven't used etomidate for many, many years for induction. Concerns over the steroid response. You also you see that 20% of patients got succinylcholine, again, an agent I haven't used for decades now, and is one of the very few things that I have absolute rules, so I tell my residents and fellows not to use in the ICU. So again, practice varies. So would the results be different if you use more propofol, which is a drug I often use? And I just noticed, maybe I'm getting older, how few direct laryngoscopies there happen. It's all video now, but as I will still use the direct view, as that was the way I learnt. One thing that we don't see an effect, could say, did you give enough fluid, as you hinted at? It's a question we can't answer. I think you probably did, and again, there was no evidence that these patients were sicker than your previous trial. Actually, the rate of collapse was slightly less, so I don't think that is the answer, although we obviously can't say for sure. But I want to come back to the subgroup, just to comment. You obviously stopped the previous trial for futility, and then done another trial in that enriched group, and again, you see futility, that there was no difference. Just one question. Would it not have been better just to carry on the original trial and not stop a small trial, a few hundred patients, for futility? Would it have been better to go on with, presumably what we've seen now is a regression to the mean with larger numbers, and actually if you'd carried on and done the first trial, this spurious subgroup, which maybe, spurious subgroup may not have been seen, and we wouldn't have needed prepare 2. So, in summary, how do I interpret this? I think for sort of clinical interpretation, I think it means that there's no justification for routinely giving a 500 ml bolus to all our patients that we provide this emergency intubation. I think, though, it's important, inclusion criteria required the physician to say that they didn't think a fluid bolus was needed. There will be some patients who will be hypovolemic, and I think it is important to correct that hypovolemia if you really think it's present. I was surprised it was so small from your screening logs, but maybe that is the case. But in those patients where there is hypovolemia, I think it would be unwise to remember, it would be wise to remember that they were excluded from this trial. So those patients may still need fluid. I think then, well, what should we do clinically? Still, in 20% of these patients, they are having cardiovascular collapse. So how best do we treat them? My thought, if it's not the fluid, and therefore it's not the venous return and cardiac output that's affecting the blood pressure, then presumably it's the systemic vascular resistance. So is the next trial, as we talked yesterday about a trilogy of trials, is PREPARE 3, testing whether or not you should be giving vasoconstrictors at the same time as your induction adients. So maybe I've started your next grant application for you, but I'll end there and open up for the discussion amongst the panel. Thank you.
So thanks, Tony. So no slides, that was awesome. And you've set the bar for all of us. Let's have a response from the authors.
Yeah, thank you. I think those were really wise comments. I think I'd love to respond to all of them. The hardest part will be remembering all of them. Those were some really, you may have to prompt me. So I think just recalling the ones that I can grasp, and we'll have Derek come up and give his answer as well. I think those were a lot of great comments, and I can describe our rationale for them. I think the first is, I think if I were looking at the paper in this body of work, I would have the same question. Why did you stop Prepare 1 when enrolling more patients may have resulted in the same answer more quickly? And I'll remind you that this was a blinded trial with pre-specified futility criteria. So the trial was stopped when the DSMB saw an overall signal of futility. And it was only long after that, when the trial was unblinded and analyzed, that this subgroup was recognized. So I'll tell you what I did in response to that was I did not write a futility criteria in our subsequent trials. Because I think that this shows that you might, even in negative trials, you often learn important things, and I wonder the same. If we'd gone to our initial sample size in Prepare 1, would we have obviated the need for Prepare 2? But there was no opportunity to make that decision in real time. So I think that's a great comment. I think regarding the outcome, I think it's a great comment. This is not the most patient-centric outcome, and I think if we had shown a difference in cardiovascular collapse that was discordant with or not paralleled in mortality, you'd still have questions about the clinical significance. I think I'll borrow an answer from one of our panelists, Lars Andersen, yesterday, when he was asked about the importance of ROSC in cardiac arrest. So I think we're starting from a place where we know very little about this procedure. When we started doing this work 10 years ago, there had been one randomized trial in emergency tracheal intubation among ICU patients. This is the 8th our group has conducted, and this is one of the largest trials of tracheal intubation ever conducted. And even still, we would be dramatically underpowered to look at an outcome like in-hospital mortality. So the peri-procedural complications are common. I think the attributable risk of contribution to in-house mortality is likely to be small. And to power a trial for in-house mortality, a trial evaluating tracheal intubation would have to be really echelons larger. And I think if you were going to affect in-house mortality for a cardiovascular-based outcome, it would be through this intervention, this causal chain of cardiovascular collapse. So I think now we know there's no difference in cardiovascular collapse. I think we don't need to do a trial 10 times larger looking at in-hospital mortality. So let's see, we've talked about the rationale for the trial, we've talked about the sample size and the primary outcome itself. The intervention windows, I think, is a great question. So there are trade-offs. So as you mentioned, critical ill patients have lots of interventions at the time of intubation. So you intubate a patient, you're then starting a sedative drip, you're starting mechanical ventilation. So the competing risk and other causes for hypotension in that setting are significant. The longer your outcome, the more likely you are to pick up noise from other things. The shorter your outcome, the more closely it's linked to the exposure of interest of intubation. So I think we had both academic reasons to shorten that outcome and keep it short, trying to make sure it was clearly linked to the intubation procedure itself and not some other exposure after intubation. And there are also practical considerations, that this is a trial in which we had to have a clinician who was not involved in the procedure. In our unit, that was a charge nurse. Other units, that was a respiratory therapist or someone else, even a trained research personnel who had to be present during the whole procedure. So for clinicians in particular, there's only a certain period of time where it's reasonable to ask them to stay at the room continuously monitoring blood pressure. So I think there's some pragmatic concerns as well. So I think those are the main questions that were raised during the editorial that I'll answer, and I'll turn them over to Derek to see which ones he can recall and answer as well.
Thanks. I think Jon did too good a job, and I'll ask you, Tony, what burning questions remain from your excellent editorial?
I think you probably covered them, and perhaps to open it up to others, maybe. But I'm glad, just comment that the issue of futility, I mean, maybe we've addressed that now. You said you didn't enter it for your other charters. And I think something I've realized in experience of trials is that it is important what you write in the charter. And so in my trials of 400, 500 patients, we don't have futility stop. We only stop for safety, I think, in a small trial, is my personal view. And address that going forward.
You don't want to regret what you put in the protocol. If I could have just a moment to address it, one other thing that I did catch, the comment about induction agent I think is important, and that may be another opportunity in addition to the one you mentioned, which I think is also important, prophylactic vasopressor use. But the choice and dose of sedative induction agent is another understudied area. It's not entirely unstudied, of course, but and we recently had, speaking of propofol and etomidate, the secondary analysis of the INTUBE study come out in Blue Journal just recently, suggesting that there may be an independent association between cardiovascular collapse and choice of propofol as an induction agent. And of course, the rate of cardiovascular collapse that they observed in the Intube study was pretty high, and perhaps driven in part by that factor, which is evidently more common in the centers that were in Intube than in our trial centers. So I think you raised a lot of really wonderful points. Most of them were questions we are also asking ourselves, and appreciate your insight.
Thanks, Derek. Okay, so time for the panel. But first, let me reintroduce many of these folks that we met earlier. So on the far left is Professor Liz Wilcox. She's from the University of Toronto. Welcome. Next is Professor Lennie Derde. She's also involved in Remap Cap. She's at UMC in the Netherlands. Tony, you've met. Lars Andersen yesterday. He is at, say this, Aarhus University. Yeah.
Pretty good.
Thank you, Lars. And Andrew Althouse, who lives down the road from me at University of Pittsburgh, has joined us from a statistical perspective. So I have a question to go to Andrew first. But even before that, since most of the audience probably hasn't an opportunity to read the manuscript or in detail, I was wondering if you could just comment on the regulatory approach for the trial, and how sort of was consent involved and how that worked.
Yeah, it's a great question, Chris, and one that I think is important in this space. So what we're talking about now is a condition, emergency tracheal intubation, for which patients are usually unconscious or in distress, surrogates are frequently unavailable. So it's clearly a case like cardiac arrest where prospective informed consent is not feasible. And I'll highlight that this is the 7th trial we've talked about in the critical care space in the last 2 days. And I don't know if anyone else has noted, but 6 out of the 7 have not obtained prospective informed consent and have had to deal with the same issue of how you respect patient autonomy in emergency conditions where you have to intervene before you're able to have an informed consent conversation. And I think there are real challenges to that. So consent on the back end is different than consent on the front end. I think you see that in the consort diagrams of these trials. So informed consent prior to a trial, there are 30-40% opt-out rates. What we see in the trials in the last few days is that 1 or 2 people withdraw consent. I think whether you notify patients after the trial is over or get consent on the back end is an open area of debate in much of this work. But I think from a larger perspective, I think what we're talking about is these are interventions that patients are being exposed to every day. So every day across the country, half of patients are getting this intervention, and there are guidelines that are recommending it. And I think that kind of clinician variability, patients are already being exposed to that, but we're not learning anything from it. So the criteria in the US for when consent is impractical, there are only 2 options. There's a waiver of consent and a process called exception from informed consent, or EFIC. The criteria for waiver are 2 basic criteria. So you have to demonstrate that consent is infeasible. That's clearly the case for cardiac arrest and emergency tracheal intubation. And then you have to demonstrate that the trial intervention is minimal risk. And the argument we and many others have made in this space is that when you're looking at things that are already being provided to patients, they're different than drug discovery trials or even vitamin C trials where things are available but not in routine care. This is something that patients are receiving across the country every day. And right now there's provider practice variation that's arbitrary. And if you structure that same variation through a clinical trial, you are not exposing patients to any different interventions than they would receive in clinical care, but you're learning something and improving the care both for them and for future patients. So our group thinks that for questions like this, when there is clear equipoise and clear provider practice variability, that's really the answer to that is a clinical trial, and that being enrolled in a clinical trial like that poses no more risk to patients than receiving the same intervention as part of clinical care.
Great. Yes. And so we've heard a lot about sort of embedding these trials in clinical practice and with our nudges and augmenting clinical decisions. So thank you for reviewing that. All right, Andrew. Composite outcome. Take us through sort of your thoughts about this.
Yeah, so with a composite outcome, or something that maybe we will get as a surrogate for something that we really care about, maybe affecting which is downstream, mortality or survival from the hospital. I think the comments, from the trialists are really important. That first you need to see if it affects the pathway by which you expect maybe to improve in hospital mortality. If you say that you think it's a pretty long stretch that a therapy would ever improve hospital mortality or hospital survival, if it doesn't reduce cardiovascular collapse, then it seems very reasonable to start with that, maybe, I don't know if I want to call it a lower bar, but start there, and if you don't get past that, then we don't need to do the 50,000 patient trial to see if it'll reduce hospital mortality. The one other thing I was going to comment on just a little bit, as a statistician, I can admit that the best trials are the ones where the answer is so obvious that you almost don't need the data analysis. You look at the raw outcomes, and it's pretty obvious from this trial, I think, what the story is. The one thing I was going to comment on a little bit, because it might draw some attention, is the adaptive sample size re-estimation. We might actually go even a bit further into adaptive trials a little bit later this afternoon. But sometimes when I speak to my clinical colleagues, they're a little bit skeptical of any sort of change to the trial. They change the sample size, or they change something about it. Are they trying to trick me, or are they trying to get a positive result here? And I just want to go over that very briefly, why we would do that. In this case, you all know that when we design trials, we're taking guesses at the very beginning about how high do we think the event rate's going to be, about how many patients do we think we'll need to test the question. So in a statistically rigorous way, you can have a blinded sample size re-estimation that just uses the event rate observed in the control group without peeking at anything else about how the treatment effect is going. And then you can say, do we need to get a little bit bigger than we'd planned on? So I do want to compliment you guys sort of on learning the lessons, as you said, as you go. I think I certainly feel like I'm always learning new methods and trying to think, all right, what do I want to do in my next trial? I think that was a really clever decision here, because it did avoid the dreaded underpowered trial. We got so close, we didn't quite get there, and now what do we do with the findings? I think that was a way to insulate yourself from that. So very, very nicely done.
Thanks, Andrew. All right, so Liz, I'll go over to you. Was this the right question? Yeah, there was a very particular population that was enrolled with some interesting exclusion criteria.
Here's my next pivot of the conference. Thanks, Chris. I think, first of all, one thing I wanted to say is that reflecting on yesterday's comments in terms of publishing in high-impact journals, I want to congratulate the consortium, because this is like a network of collaboration who's been extremely successful over the last couple of years in delivering high-impact trials. So congratulations for that. In terms of whether or not this is the right question, I'm not quite sure how to answer that, Chris, in all honesty. And kind of jumping off what Andrew had said in terms of the adaptive sample size design, when they had a previous trial to kind of inform those numbers, in selecting a population, a more specific patient population in a group of units that are probably really early adopters of changes in practice in terms of pre-ICU care. My question in not answering your question to Derek is whether or not they realized that there were some changes in their care practices between Prepare 1 and Prepare 2 that maybe led to the sample size recalculation, because maybe they weren't seeing as many events because they actually changed their practices, because the centers who have been involved in each of these studies have been consistent, which also might speak to some of the generalizability concerns.
It's a very good question. It's a very good question, Liz. I think and it gets back to Tony's earlier observation about the power calculation too, that the predicted, the original power calculation was based on expected incidence of the primary outcome that ultimately derived from these subgroups from Prepare 1, which was higher than our observed control event rate. However, if you look and compare the overall event rate in Prepare 1 to that in Prepare 2, in fact, even if you just compare the no fluid bolus groups to each other and vice versa for the fluid bolus groups, you actually see almost identical overall event rate. And so it seems most likely to us, although possible that there's another explanation, but it seems most likely to us that this is regression to the mean, and just that the higher event rate in the control group in those subgroups that we observed in Prepare 1 were chance findings and just sort of skewed by the smaller sample size of a secondary analysis.
I will make one corollary comment, which is the whole reason you do this work is to learn how to take care of patients. And this is the 8th trial in this area. We've got 3 more trials that we're doing now for related questions, and I'll highlight that we've written not the grant, but the trial protocol for the pressure trial that you proposed, so you're very forward-thinking. And yes, the answer is by doing this work, you learn things and you adopt them for your patients. So I think the best example of that's bag mask ventilation. We conducted the PREVENT trial at the same time as PREPARE 1, so the majority of patients were co-enrolled, so half of patients through the randomization received bag mask ventilation. We learned the results from PREVENT 1 that bag mask ventilation appeared safe and effective at preventing hypoxemia, and now the vast majority of our patients receive bag mask ventilation. And I think if you look at the raw numbers of hypoxemia in those 2 trials, it shows that our patients are benefiting from this process. So I think I completely agree with Derek that overall the cardiovascular collapse appears pretty similar between PREPARE 2 and PREPARE 1, and I think that 25% event rate in the population receiving bag mask ventilation likely was a false signal in that subgroup. But I do think that the whole reason you do this trial is to learn what's best for your patients, and we're finding locally that doing that and adopting those, that's the important part, is learning and then adopting those practices is helping our patients.
I was wondering, just in follow-up too, is it's very difficult for me to go down to the emergency department and not have my resident or fellow already have an echo probe on the patient's chest doing a fluid assessment. So in identifying like patients potentially more likely to benefit from fluid, do you guys have any data in terms of, especially in Emerge, they use POCUS a lot?
Yeah, another great question, and I'm beginning to suspect you may be reviewer number 2.
I was not. Chris can confirm, yes.
They're excellent questions. The truth is, as Jon mentioned, tracheal intubation is a rapidly occurring, emergent, often, certainly almost always very urgent procedure in the ICU space. And so we didn't feel that it would be practical to ask clinicians to protocolize a volume assessment or find some other means of tailoring or personalizing the volume resuscitation delivery for an individual patient's characteristics. However, and this gets to another thing that Tony mentioned earlier about the relatively low number of exclusions for hypovolemia, I think it's important to also notice that across all of our sites, the 11 sites that enrolled in PREPARE 2, all of them have a pretty robust general approach to assessing and treating hypovolemia. And all of them, we actually surveyed them in response to Revere 2, I think it was, and are able to say confidently that all of us do actually optimize as to the extent we can. I grant you that's a vague term since there are different approaches to this question. But try to optimize volume status prior to initiation of tracheal intubation, and the initiation of the intubation is the point at which these patients were screened. And so that may be in part an explanation for your, I think, important point that many of these patients, we don't know, we didn't collect data on this, but presumably at least some of them might have gotten fluids for another indication at some point in the peri-intubation period. It's certainly possible, but we can't speak to that really with the results of the study.
So I know there's some questions in the audience. I just want to grab a few more thoughts from the panel. So Lennie, you've been involved in both pragmatic trials, perhaps like REMAP, as well as others that are more tightly controlled. I wonder sort of what you're thinking and how you're reflecting on this.
Thanks, Chris. So first of all, guys, really congratulations, because I do think that whether it's pragmatic or controlled, what you're trying to do is kind of learning from previous experiences and kind of zooming in more and more on improving care for the patient. I think that's a great strategy, and I think your group's been doing really, really well at that. If you're thinking about pragmatic and controlled, the question is this a simple problem or is it a complex problem? And I think you've both said that intubation is a complex problem, right? So it's not just the 2 minutes, it's the preparation, as you just said. It may be, as Tony said, the hour after. So I was wondering what your kind of, framework for thinking about future trials is, because you can say, okay, now I'm picking 500 cc's of fluids, but if I don't want to give my patient fluids, I may choose a different sedative, or I up the noradrenaline, or there are different knobs you can turn. So do you have an approach for that in your group, or an idea of how to do that?
Yeah, I think that's a great question. We're here today representing the Pragmatic Critical Care Research Group, and a lot of my work's been in that space, but I certainly have conducted trials along the entire continuum from these very pragmatic trials to first-in-drug trials among COVID patients. And I think that there's no one perfect trial design. I think in every trial design, you're trying to think, what's the best way to answer this question? And I think when your questions have to do with evaluating things that we're already doing in practice and understanding their effectiveness, I think those trials tend to lean towards more pragmatic trial methods, particularly when they have simple interventions. And I think tracheal intubation is a complicated procedure during which you have 20 independent decisions, but we were controlling one pretty simple decision: do you give 500 cc's of fluid or not? I think the further you get the other end of the spectrum, when you're doing first-in-man drug trials, when you don't know how things are going to work in terms of what the adverse events will be, what the outcomes are, you need lots of safety screening. Or it's a very complicated intervention where you have to titrate the drip minute by blood pressure. I think it'd be very unsafe to propose embedding that intervention among routine care like we do for our pragmatic trials. So I think, I hope that we are recognizing as a community that many of the things that we have been doing for decades have little to no evidence. Trial after trial, like the one we just conducted, shows that many of the things that we do every day are not helpful or even harmful. And I think we need to be evaluating our own practices through more pragmatic trials. I don't think that pragmatic trials are the right solution for every question. And I think that they should be complementary to the more explanatory trials.
If I can come back with one more question, Chris. So I fully agree to that, and I fully agree that, guidelines, they're good, but they're usually not based on heaps and heaps of high-quality evidence. So somebody I know calls guidelines lampposts for drunk people, right? They're there to hold on to, but they're not there for enlightenment. So I think it's great to do comparative effectiveness research, really, really important. But the question is, if you only modify the 500 cc and you have no control at all, like what was the between site variation or the between doctor variation and all these other aspects of the trial? So I think we can still be pragmatic, but kind of, I don't know, maybe investigate these things in relation to each other, and then we'd likely come back to Andrew, because then it becomes like a platform trial or something like that. I don't know if you...
Well, then I think that's a great question. I think this also highlights the comment from Dr. Gordon earlier, which is, there's so many things he saw in this trial that don't represent the way he takes care of patients. And I think people are often surprised that the way they do things are not the way that someone else does them. And that's true not just between the US and the UK, that's true in my own hospital. So if you come in today in respiratory distress, you'll be intubated in one way in the emergency department, in a different way in an anesthesia-led unit, and in a third way in a critical care unit. And those are the same patients, and there's probably one way to intubate them correctly, and we're probably all doing it wrong. We've probably all got things that we're right about and all got things that we're wrong about. And I think when you put people in the same room, we've discovered that people are surprised about what parts of their practice are not standard, and that actually makes those same people more open to investigate those questions. So I think that's been an important part of our process, is learning which questions are actually questions. So, and I have to admit, I'm not always on the right side of this at the beginning. So before PREVENT, I was taught by emergency medicine airway gurus to never bag mask people. So that was something I did in 0 people prior to my trial showing that it was likely life-saving. So I think that's important to understand that there are variations in practice, and that's why we need these trials. I think the separate part of your question is about co-interventions. There are 2 approaches. You can either protocolize every co-intervention, or you can let decisions be made in usual care. I think that there are pros and cons to both. I think the challenge if you protocolize every intervention, one is it becomes harder to embed that in care when you're being very restrictive. People are often willing to have equipoise about one question, but when you protocolize 10 parts of the procedure and 9 of those don't look like what they do in everyday practice, you're gonna have a hard time conducting that trial. And the second part is then you've only answered a very narrow question. Now I know that a fluid bolus works among people who are getting etomidate, who are getting BiPAP for pre-oxygenation, and if my practices don't look like that, I don't know if these results apply to my patients. So I think the pros, the advantage of a pragmatic trial that allows, that controls the intervention you're interested in and allows variation in those co-interventions, is that you then have the opportunity to do subgroup analyses and see, do those things modify the effects of the intervention, or is it true that this result applies to patients who are receiving all of those different co-interventions?
Do I have time for...
Well, we've got time. Yeah, we're good. Yeah.
Sorry. I agree with everything John said, but I wanted to elaborate. even or dive a little deeper and maybe even extrapolate your question a bit into the clinical implications of the complexity of the procedure, because I think in some ways, at least personally in my own practice, this is the most impactful aspect of this study, which didn't show a benefit of something that I hope would work, is that I now have at least a little bit of liberty to use my headspace, is the term I use with my fellows, but to spend my energy and my staff's focus and attention, perhaps instead of getting a third IV, on something else. And I would hope that by default, at least, sometimes I'm obviating a complication by focusing on other things that might actually be important. Granted that there's a lot of things we don't know for sure how important they are yet involved in this complex procedure. And one other comment I wanted to make is that in addition to all the points John made, I think another important ethical sort of reason for not protocolizing too heavily in a study of this nature is that you're conducting it under waiver of informed consent, in which the rationale for that waiver is that the providers feel good equipoise about either intervention. And if you don't allow them liberty to react to, let's say, a complication of that intervention, or to adjust their practice the way that they feel is best for a given patient, it introduces new ethical problems too.
So thanks, and I'm going to come to Lars and then the audience. There's some amazing trialists in the room who've conducted fluid trials, and so I look forward to your input. But Lars, first you.
Yeah, so congratulations on a great trial. And you say it's pragmatic, but there's still like almost 100% adherence, so I think that's really excellent. I wanted to come back to the primary outcome, because I think it's extremely important, and I think maybe we can learn something from you going forward. Because I think it's something we struggle with in acute and critical care in general, that it's very hard to define outcomes that are not mortality. So I think that the concept of cardiovascular collapse is excellent as an outcome, the concept of it, because that's what we're trying to prevent. We're not trying to prevent in-hospital death. There might be a tiny, tiny effect on in-hospital death, but it's going to be impossible to ever detect, because we're talking less than 1% probably. My question is more related to the definition of cardiovascular collapse, which I think is much more challenging than the concept, which I think most of us can agree on. And it's a composite outcome, as we have discussed, of death and cardiac arrest, low blood pressure, and then this receipt of new vasopressor or increase in vasopressor dose. And when you look through the paper, that's sort of what drives the outcome, the vasopressor. And I think when I intubate someone, to me it's not a bad thing if I increase the vasopressor. That's just good clinical practice to avoid hypertension. So I was wondering what your thoughts were about that and how you think of that as a good versus bad outcome. And also I noticed that if the patient had an increase in vasopressor prior to the induction agent, so sort of prophylactic increase in vasopressor, it was not counted in the outcome. Is that correct? And lastly, if patients had a fluid bolus because they were hypotension, so sort of as a safety treatment or as a treatment similar to the vasopressor increase, it was also not counted in the outcome. So I was curious about your thoughts of that, and how are you gonna stick with that outcome in future similar trials, or are you gonna try to change the definition so it perhaps becomes more aligned with what at least some clinicians like myself would consider good versus bad?
Yeah, I think that's a great question, and actually it helps me recall a question that maybe I'll address first, which was one that was brought up during the editorial, which is that it's challenging when you have a composite when clearly there are different values to the different aspects of the composite. I think we can all acknowledge that increasing vasopressors is not as severe as cardiac arrest. So there are novel analytical solutions that have been proposed to deal with the problem, that there's an order in severity. These are not all the same. This is the same challenge that the MI and cardiac literature have had for a long time with their outcomes, like major cardiovascular events. And I'll highlight that there was no difference in any component of the outcome, and that analytical methods that attempted to order these outcomes and their severity, like ordinal regression, provided similar results. I think your question is an astute one about, why did we allow vasopressors before intubation, and then consider that to be an outcome on the back end. And I think it's there's similar questions about what your threshold for hypotension should be. So ours is a systolic less than 65. I think everyone would recognize that's a pretty severe cutoff. The idea being that what's the blood pressure at which you would prefer to avoid it having ever happened? That's the threshold that we wanted to set. And then there's a competing risk problem. If people clearly have a blood pressure that's going to be less than 65 and you start a vasopressor, that clearly is something that you have to account for in your outcome. So that's why we chose to include both of those, because they're clearly things that physicians are responding to bad things happening, and if they don't respond, it's on the causal pathway towards a bad outcome.
Yeah, the inclusion of patients given prophylactic vasopressors, which occurred about 12% of patients overall were given prophylactic vasopressors, either an increase or a new vasopressor prior to tracheal intubation. That was included in part for some of the reasons we mentioned earlier, this complexity of care and also the allowing physicians the liberty to use the interventions that they think are most likely to benefit their patient in this waiver of consent study. So the best we could do were to track those carefully, track important co-interventions like that carefully, and perform sensitivity analyses. In the case of that particular one, we did look at that. It didn't modify the effect to exclude patients who were receiving that co-intervention, but it's just one of many things, some of them probably not captured or perhaps even not known to us, that might be, that clinicians are probably doing as part of the normal variability of practice, and that might conceivably affect the outcome in this case.
Okay, good, thanks. And I'm really excited to hear some of the audience's input. I'm actually reflecting a little bit on your comments while folks think of their questions. During trials of early cortical therapy, of whom there are many in the room that conducted those, there were multiple steps to an intervention. And when we saw a trial result, we thought, which one of the parts was working or accounting for that treatment effect? Whereas here we have, again, a complex clinical moment, and we've taken off just one tiny piece, and yet we're saying, well, all this other stuff is going on. And so I don't really know whether that one small piece matters. It's like sort of a challenge to sort of get the design right for these complex moments. So Bala, I see you have your question, hand up for a question. Yeah, you want to go first?
Thanks, Chris. And I have a comment and a couple of questions. The first is the use of etomidate. It's cardiostable and doesn't cause immediate cardiovascular hypotension, but certainly is associated with delayed mortality in intensive care. So if you're using cardiac mortality as an endpoint, then that could be a potential confounder. I guess that's just a comment. In one of your slides, you reported the lowest systolic blood pressure in both groups was around the 110 mark, and the maximal drop was about 6 millimeters of mercury. And so we normally wouldn't be giving a bolus of vasopressors for such a drop in blood pressure. So I'm just trying to understand, I know that wasn't sort of controlled as part of a protocol, but do you think clinician behavior at that stage may have influenced the use of pressors in both arms, and people were anxious to avoid hypotension and gave vasopressors? And the second comment is, I wasn't sure they reported the failed intubation rates or the difficult intubation rates in the study. Were they balanced in both groups?
Yeah, I think that's a great question. I'll highlight that the data you're referring to, lowest blood pressure and change in blood pressure, those are essential tendency measures. So those are what's happening at the median. And I think most of what we're seeing in the outcome is not reflected at the median. So only 20% of patients experience the cardiovascular collapse, and a little less than 20% receive vasopressors. So we could get, but don't have off the top of our heads, the lowest blood pressure that resulted in physicians administering vasopressors, but it's significant. I can tell you it's almost assuredly a larger change than was occurring at the median. So that's the answer to your first question. I'm sorry, your second question was?
The intubation rates, the difficulty intubation.
Yes, we have extensive data in the supplement about difficult airway characteristics and outcomes of the procedure itself, and they were similar between groups.
Yeah, about 80% first attempt success, as defined by a single introduction of a laryngoscope in both arms.
Thanks, Bella. I see Professor Malin is next.
I know it's not an obvious person, but just are you saying that the actual intervention, the intubation intervention, is in the causal pathway to cardiovascular collapse? Is that?
Well, the outcome window we're looking at is certainly temporally connected to cardiovascular collapse in that period of in that moment of intubation, and we're saying that. We think it's unlikely that you're going to affect mortality in the hospital if you see no difference in this very proximate outcome of cardiovascular collapse at the time of intubation. That's the point I was trying to make.
Okay, so if it's associated with those poor outcomes, how many of your patients at the point of intubation were spontaneously breathing, and could there be an alternative approach?
So you're asking about. Let me make sure I understand your question correctly. The vast majority of our patients received RSI, a sedative, and neuromuscular blockade. Are you asking about awake intubation, if that would have been an option?
Yeah. Prior to you giving those, were they awake and spontaneously breathing?
Yes. The vast majority of the patients were awake and spontaneously breathing. We didn't capture that as a study variable, but the majority of the modes of oxygen delivery being provided were modes that require spontaneous ventilation. So yes is the answer, that most patients were spontaneously breathing at the time of enrollment and at the moment of induction.
So would an alternative to a non-invasive ventilation? That's what I'm trying to drive at.
Yeah, so the trial, the requirement of positive pressure ventilation was after induction. So at the point of induction, patients are given sedatives, they become hypopneic and apneic, and there's this inherent delay during which we are required to either watch patients and observe them or provide positive pressure ventilation. That was the focus of the PREVENT trial that showed bag mask ventilation during that period, decreased hypoxemia without affecting aspiration. And that was part of the foundation for the PREPARE-2 trial, that every patient in this was getting either bag mask ventilation or non-invasive ventilation during that period. So certainly after induction, every patient eventually becomes apneic prior to the start of intubation. I think a separate question is, a great comparative effectiveness question is, do we have to do RSI in every patient? I think is a separate question that you may be asking. Our trial wasn't positioned to answer that, but I think there are our hospitals are all hospitals that have historically performed RSI for every critical care intubation. That's not the case at every hospital in the US or globally, and I think that's another good topic for a future trial.
So let's go to Twitter, yeah? And how is that going with questions online from our audience around the world, if any?
Yeah, we've got a few questions, and I suppose we've already sort of maybe touched around this, and in terms of the dose of fluid, and Tony thought it was enough. We've had a pediatric trial this morning, and we actually had a comment from a veterinary surgeon about dosing in mils per kilo, and was there any consideration that in an intervention that we don't know an awful lot about, was 500 was it the wrong thing to do? Should we have used 10 or 20 or different boluses of fluid?
Yeah, that's right. So the question of whether or not to deliver a standardized intervention, a certain volume, or to personalize it, weight-based dosing, is, I think, a valid question, and it's something that we just didn't answer in this trial. One of the practical concerns, though, in delivering an intervention like this, John alluded to it earlier, but having enrolled in this trial, I can tell you it took some work to get that amount in to a patient on average. A lot of preparatory work, a lot of coaching of our enrolling physicians to have the fluids ready, even if they didn't know for sure yet if the patient was was, which group the patient would be randomized into, having the team ready and getting intravenous access if needed. And so a lot goes into it, and I think there are limits to the amount of fluid that you can effectively deliver in this setting. And so sometimes it may be that a larger volume of fluid would be feasible, but in many cases perhaps not. And so we chose to standardize our intervention by volume so that it would be standardized. But I think it's a valid question and one we didn't address.
I'll just say that personalization or larger volumes are questions not addressed by our study, but they're also not what was being recommended or done in the field. So the volume of fluid that was broadly recommended in international guidelines was 500 cc's. That's the volume that had been reported in observational studies, and that's the volume we tested. I think it's a fair question to ask, would more volume or personalizing your assessment in any way change the answer? We didn't see evidence of that in our subgroup analysis, but it's possible that we didn't collect the right effect modifier to identify that. As Derek mentioned, of the intubation trials, or trials we've conducted in general, this was a hard intervention to deliver. So if anyone else has a very strong feeling that more fluid or an echo before intubation would change the effect, I very much encourage them to try to deliver that intervention in a trial.
Gauntlet is thrown down. All right, so John Myberg has the microphone. I recall that you have a review in the New England called Resuscitation Fluids, so I'm excited for your question.
Thank you, Chris, and thank you all for this excellent discussion and presentation. I think the conversation has been very, very good and very balanced, but I would like to just perhaps put my take on the take-home message here. At the beginning of your talk, you very nicely articulated the hypothesis of the generation of cardiovascular collapse, peri-intubation, and you identified three main areas. One was hypotension due to a lack of venous return because of positive pressure ventilation. That's an important driver. The second was catecholamine non-responsiveness from endogenous responses, and the third was loss of tone, which Tony referred to as vascular resistance, induced by the sedative agents. What your study has done primarily is identify one of those variables, and that was primarily to administer a bolus of fluid, primarily to increase venous return by increasing cardiac output. And you made quite clear assumptions that this was not primarily to correct hypovolemia. It was a cardiac augmentary process. And your study has shown that that didn't happen. And I think that's a very important conclusion, that the use of perioperative or peri-intubation fluid boluses, primarily to increase cardiac output, venous return, in this context, didn't achieve the success. And I think that really, for me, is a take-home message, because the comments around the complexity of the composite outcomes are very valid here, particularly the adjudication of vasopressor usage. It's entirely an operator-dependent variable. It's not a patient-centered outcome, and therefore that's a confounder. And maybe the catecholamine trial down the track will address that particular question. And equally, you cannot put parity with a cardiac arrest and death in the same box. So the main thing driving here is the effect on hypotension, which clearly didn't happen. And in the presence of Professor Maitland, OBE, you have to refer your results in the context of the FEAST study. The FEAST trial was a game changer, whereby Catherine and her colleagues clearly identified the adverse effects of bolus administration to maximally compensated febrile children. Now, I accept your patients are different, but that was almost certainly maximally compensated by the catecholamine surges. That was then ablated by an anesthetic agent. The volume of fluid that you tried to improve cardiac output didn't occur, and the collapses were worse. Now, that's not a negative result. That's a very important positive result. And if you take that further, given the excellent hypothesis generation, the development of the subgroup analysis, and all those things, okay, I think what you've done in your trial is provided new information that would seriously question the use of an IV fluid bolus in this context to critical patients. And I think that's a good result. It's a very important contribution. I wouldn't get too fussed about the complexity of the outcome measures, the confounders of catecholamines, okay, and And I think these uses of the different agents and succinylmethonium and etomidate are valid. But I think the key question that you articulated at the beginning of your talk about the role of IV fluid boluses in this context to address peri-intubation collapse, okay, has been largely addressed by your trial.
Thank you. And actually, we're a little early on time, but that is the perfect comment to end on. So thank you, John. I'd like to thank everyone here on the panel, as well as the investigators, for sharing Prepare 2 with us.